Welcome to MedEd's production of the Electronic Fetal Monitoring Certification Exam Review. My name is Jeffrey Fouche, and the title of this module is Physiology of Fetal Oxygenation, Extrinsic Factors. This module will cover the extrinsic factors that are related to fetal oxygenation, and extrinsic factors are those factors that are outside the fetus itself. So what are the extrinsic factors? Extrinsic factors are those things that are outside the fetus's body or outside of the control of the fetus itself. And these are things like maternal oxygen transport, uterine blood flow, placental integrity, and umbilical blood flow. And the extrinsic factors are really important to us because these are the things that we can have some impact on. Those intrinsic factors that we were discussed in a previous module are really not amenable to intervention by us because we really can't do anything to affect the fetus itself because of course he's in utero. But we can do interventions to assist with the delivery of oxygen as they relate to extrinsic factors. So we have a little bit more control of those, and these are the ones that we typically respond to when we're looking at the fetal heart rate tracing. And we set our goals and our interventions related to modifying these extrinsic factors. So we'll start with a look at the oxygen pathway. And remember, this is the pathway that oxygen molecules must take in order to reach the fetus. So we start with the environment, and we go through the mom's lungs, her blood, her heart, her vasculature, her uterus, the placenta, through the umbilical cord, and finally to the fetus. And each little oxygen molecule that goes to the fetus has to go through every step in that oxygen pathway in order to be successful. And so any disruption anywhere in that pathway will cause an alteration in oxygen delivery to the fetus. So let's take a look first at the external environment. We know that oxygen makes up about 21% of the inspired air that we breathe. At sea level, oxygen exerts about 150 millimeters of mercury of pressure, and that's what we call the PO2. The PO2, or that pressure of oxygen, will decrease at higher elevations. The PO2 will also decrease as molecules, those oxygen molecules travel along the oxygen pathway. And so by the time they reach the fetus, that PO2 is going to be lower than it was in the environment. The maternal lungs. We know that inspired air mixes with less oxygenated air leaving the lungs, which further lowers the PO2 level. At sea level, the air that is being breathed into the lungs is about the PO2 is about 105 millimeters of mercury inside the alveoli. Once inside the alveoli, oxygen will then diffuse across a very thin air-blood barrier and enter the pulmonary capillary beds. From the capillary beds, then oxygen is then delivered back to the vessels. We know that any damage to the alveoli will decrease this gas exchange. So if there's a disruption there, then we're not going to get the adequate gas exchange of that oxygen from the air into the alveoli. Some examples would be, we know that asthma decreases oxygen delivery to the alveoli because of the constriction of the airways is going to physically restrict the amount of air that's brought into the lungs that can be then sent to the alveoli. Pulmonary edema will block gas exchange because there is liquid or fluid there that is blocking the intake of oxygen in the alveoli. Hypertension can cause capillary damage in the alveoli. So even though we're delivering oxygen to the alveoli, if there's capillary damage, those capillaries are unable to pick up that extra oxygen in the alveoli and deliver it to the body. A pulmonary embolus can alter oxygenation because it will occlude a pulmonary vessel. So wherever that embolus is, then it's going to block the blood from traveling to that part of the lung, and so it's not going to be able to pick up oxygen. Or if it's after the alveoli, it may not be able to then deliver that oxygenated blood to the heart. We do know that medications can also alter oxygenation in the lungs. Things like narcotics and magnesium sulfate decrease ventilation. And so if we decrease ventilation, we're decreasing the amount of air that we're moving in and out of the lungs, which will then decrease the amount of oxygen available in the alveoli for gas exchange. Maternal blood. So after oxygen diffuses across the alveoli into the maternal blood, more than 98% of that oxygen will combine with hemoglobin in the maternal red blood cells. And when this happens, that combination of oxygen and hemoglobin is called oxyhemoglobin. As the PO2, or that pressure of oxygen, decreases further as it travels through the mom's vasculature, the oxygen then will leave those hemoglobin molecules and diffuse across capillary beds into the peripheral tissues. And that, when that happens, we call that deoxyhemoglobin, once the hemoglobin has released that oxygen. There are other factors that can cause a decrease in the O2 affinity, and that those things will shift the oxyhemoglobin dissociation curve to the right, which causes oxygen to leave the hemoglobin more rapidly. So if you look at the picture there, you see a picture of the normal oxyhemoglobin dissociation curve. And what that's telling us is if you look at the bottom, that's measuring our partial pressure of oxygen in millimeters of mercury. And going vertically on that graph is the oxygen saturation. And remember, that's telling us how saturated the hemoglobin is with oxygen molecules. So we can see that normally at a PO2 as low as 40, we're still getting a 90% saturation rate. And so that is going to really allow that oxygen to travel to where it needs to go. But if something causes a shift in that curve, a shift to the right, as you see in that picture there, in that dotted line, that's going to alter the ability of the oxygen to remain saturated at lower pressures. So now if we look at that same 40 millimeters of mercury in that PO2, look, we're down to about 60% saturation. And so it's going to greatly affect that. And so you can think about oxygen affinity as kind of how sticky the hemoglobin is to attract oxygen molecules. And so some things that can cause that shift in the curve would be things like fever, metabolic acidosis, and certain hemoglobinopathies like sickle cell or thalassemia. The maternal heart. Any alterations in the maternal cardiac function can cause a disruption in the oxygen pathway and oxygen delivery to the fetus. Some examples would be an altered heart rate, like an arrhythmia, reduced preload. Remember, preload is what we're thinking about as the volume returns to the heart, to the right side of the heart after it has been through the body. And so that could be affected by things like hypovolemia or compression of the inferior vena cava if the mom is positioned flat on her back, for example. Impaired contractility. So that would be where the heart muscle itself is not contracting adequately to get blood out of the heart in an efficient manner. We may see that in ischemic heart disease. So if mom's had an MI, then that heart muscle is going to be necrotic and it's not going to function appropriately. We also see that in diabetes when there are vascular changes, or cardiomyopathy where the heart muscle is kind of just not pumping efficiently, or in the case of congestive heart failure where blood is then backing up in the system and the heart is not pumping efficiently. We can also have alterations related to increased afterload. And afterload is that pressure in the peripheral system that the left ventricle must have to overcome in order to get blood out of the left ventricle into the aorta. And that we think about with hypertension. So with hypertension, there's an increased pressure in those peripheral vessels. And so that makes it harder for the left ventricle then to push against that pressure to get blood out of the heart to the body tissues. Structural abnormalities of the heart may also impact the ability of oxygen to be delivered to the fetus. So if there's any abnormalities of the mom's heart or any of her great vessels, that impedes the ability for the heart to pump blood effectively. So if she's got some type of valvular stenosis, or she's got aortic stenosis, for example, that's going to reduce the ability for her to pump enough volume from the left ventricle out into the circulation. Also, she has severe valvular insufficiency, where the valve kind of prolapses or kind of causes regurgitation. That may impact the ability for the heart to appropriately pump blood out to the body systems. And then pulmonary hypertension occurs when there's damage to those pulmonary vessels, and they become constricted and hardened, and so they're not going to be able to adequately accommodate increased blood flow, and so that's going to decrease oxygen delivery and from either blood coming into the lungs or blood leaving the lungs. Those vessels can become damaged. Or if a mom has certain congenital heart defects, like a coarctation of the aorta, that's going to decrease again the amount of oxygenated blood that can leave her heart at any given time. The maternal vasculature. So after oxygenated blood leaves the maternal heart, it has to follow the arterial pathways to reach the uterus. So any interruption in the oxygen transfer at the level of the maternal vasculature will commonly result from hypotension caused by epidural placement, hypovolemia, example if she's having a hemorrhage situation, impaired venous return could be if she's flat on her back, for example, and so she's got that vena cava syndrome where blood is not returning to the right side of the heart, or impaired cardiac output. So she's had, again, a type of ischemic injury there is going to decrease that, or medications. Some conditions that are associated with chronic vasculopathy, such as chronic hypertension, long-standing diabetes, concomitant vascular disease, thyroid disease, and renal disease, all result in changes to mom's vasculature that will then result in chronic suboptimal transfer of oxygen and nutrients to the fetus because the mom's vasculature is not responding appropriately. A common one we see is preeclampsia, and it's associated with abnormal vascular remodeling at the level of the spiral arteries in the uterus, and that can impede perfusion of the intervillous space, which will then impact the ability for oxygen delivery to occur to the fetus. The uterus. Between the maternal uterine arteries and the intervillous space of the placenta, the arcuate, radial, and spiral arteries all transverse the muscular wall of the uterus. And any interruption in oxygen transfer from the environment to the fetus at this level, at the uterus, commonly results from things like uterine contractions that compress the blood vessels and impede blood flow. So as the uterus contracts, those arteries are compressed, and then we're actually decreasing the amount of oxygen that's delivered to the intervillous space, which is then available for the fetus to pick up and use. Uterine contractions and uterine injury like rupture or trauma are the most common causes of interruptions at the level of the uterus. A little bit about uterine blood flow. blood flow to the fetus is completely and totally dependent on uterine blood flow. And at term, that's about 350 mLs of blood per minute that's being perfused through the uterus. The uterine blood flow is then completely dependent on maternal cardiac output. So we have to have adequate cardiac output to adequately perfuse the intervillous space. We have to have that intervillous space for that uterine blood flow in order to adequately perfuse the baby. The uterine spiral arteries in normal pregnancy become very dilated, and they're able to accommodate that increase in blood flow and the increase in blood volume. When you have a uterine contraction, blood flow to the placenta will decrease once you reach about 30 millimeters of mercury. And once you reach 50 millimeters of mercury, the pressure there is sufficient to completely collapse all the arteries inside the uterus, and so we are now no longer delivering oxygen to the intervillous space. And of course we know that 50 millimeters of mercury is not even a very strong contraction. So it does not take a strong contraction to impede blood flow. It just needs to be a moderate contraction to really impede blood flow. And even a mild contraction at 30 millimeters of mercury will begin to impede blood flow as well. So placental integrity. And so we think about things with the placental structure, the placental function, and then blood flow through the placenta. Placental structure. The functional placental surface area is the amount of the placental fetal interface surface available for gas exchange and nutrients. It also allows for the elimination of waste products and the production of steroids and hormones. And so the structure of the placenta is such that there's a maternal side and a fetal side. And on the fetal side are those chorionic villi. And those chorionic villi are the little tree-like projections you see in the picture there. And that results from branching of the umbilical arteries and the umbilical vein. And those little tree-like projections then sit out there in these little pools of maternal blood. Because coming from the maternal side, which is the top of this diagram, we see those spiral arteries, and those spiral arteries just kind of terminate there in that intervillous space, and it just bathes those chorionic villi with blood. And so blood kind of bathes those chorionic villi, gas and nutrients are exchanged across that very thin one-cell layer membrane, and then those waste products and CO2 are then returned back through the uterine arteries there, the uterine veins. And so anything that would cause any type of endothelial damage, like hypertension or diabetes, is going to then impact those chorionic villi, and they're not going to be able to efficiently do gas exchange or nutrient exchange any longer. And certainly if there's any alterations in the mom's vasculature, like with preeclampsia, where those spiral arteries do not dilate and widen, then that's going to decrease the amount of oxygenated blood that's then delivered to those intervillous spaces. So the function of the placenta is that it acts as the organ of respiration for the fetus. Oxygen and carbon dioxide are exchanged here in the placenta, not in the lungs, because the lungs are not functioning in the fetus. There is a blood-blood barrier at the level of the chorionic villi, and it's similar to that of the blood-air barrier at the alveoli. And substances are then exchanged across that very thin one-cell membrane through various methods, either through simple diffusion, like oxygen, where oxygen just will quickly go from areas of high concentration to low concentration, facilitated diffusion, active transport, bulk flow, and then pinocytosis, which is what the cells do to kind of incorporate those very large macronutrient molecules. So let's talk about placental blood flow. Fetal placental blood flow can decrease by 50% without causing any change in fetal oxygen consumption, umbilical cord vein oxygen content, or delivery of oxygen to the fetus. And how that happens is the fetus kind of has twice the amount of reserves that he really needs, because we know that during labor, once those contractions begin, and remember, at 50 millimeters of mercury, there's no more gas exchange occurring because the uterus has collapsed those arteries. And so what has to happen is the fetus has to use the oxygen that's available in the intervillous space. And usually that's going to be twice what he really needs. And so that's going to give him that reserve so that when the uterus is contracting in labor, he's still able to pick up oxygen content from the intervillous space. And we know that maternal cardiac output, again, is the chief factor in placental blood flow. So anything that's going to cause a decrease in the maternal cardiac output will cause a decrease in the placental blood flow. So that's why we need to make sure that we maintain proper cardiac output in our moms. So the importance of the placenta in the oxygen pathway. The intervillous space, PaO2, remember that's that pressure of oxygen. The maternal PaO2 is about 95 to 100 millimeters of mercury, the intervillous space. At the blood-blood barrier in those chorionic villi, oxygen is released from the maternal hemoglobin, and it combines with fetal hemoglobin, which results in a maternal PaO2 of 40 millimeters of mercury. And so that large decrease in that PaO2, or that pressure of oxygen, is because so much of that oxygen has been released from the maternal hemoglobin over to the fetus. The chorionic villus surface area, that's the active area of the placenta that's available for gas exchange. And the greater the area, that allows for more oxygen and nutrients to be transferred. So problems could include destruction of the villi, either by infection, infarction of certain parts of the intervillous space, any hemorrhage that occurs in the placenta, or any inflammation or thrombosis can all impact the ability for blood to be exchanged in the intervillous space. Diffusion across that blood-blood barrier, that barrier is very, very thin, and it makes the distance for transfer very short. However, there are some disease processes that can impact or increase that distance. A disruption of the placental blood vessels, like damaged vessels from either abruption or trauma, allow blood to leak into the maternal system, and a vasoprevia can cause bleeding from a placental vessel. So let's talk about umbilical cord blood flow. There can be structural defects, like a velaminous insertion, a two-vessel cord, or a hematoma. There could be cord compression, either from position of the cord. So if the cord is wrapped around the baby's neck or around the baby's arm, if it's then pinched between the baby's shoulder and the mom's pelvis, for example. Certainly a cord prolapse would cause a disruption in umbilical cord blood flow. Any knots in the cord. And then we think about cord cushioning, and we think about what helps cushion that umbilical cord are the Wharton's jelly and the amniotic fluid. And the Wharton's jelly is a gelatinous substance that is inside the umbilical cord to help protect the vessels. When you see in the picture there, remember there are two umbilical arteries and one umbilical vein. And those arteries are thick and muscular, where the umbilical vein is a very thin-walled vessel. So what are some of the umbilical cord abnormalities that can impact delivery of oxygen to the fetus? One would be a velamentous insertion of the cord. And that's where, in normal pregnancy, we expect the cord to insert in the placenta itself. And so those umbilical vessels then leave the protection of the Wharton's jelly and enter the placenta directly. In the velamentous insertion, instead of inserting directly into the placenta, those umbilical vessels transverse the membrane, so they're in between the chorion and the amnion layers of the membranes, and so there is no protection to those vessels along there. And so you see in the picture there, the umbilical cord inserts directly into the membranes, and then look at that those large vessels that are then just transversing across just between those very thin membranes of the chorion and the amnion before then those blood vessels go into the placenta. And of course the danger there would be if her membranes rupture anywhere close to that very large vessel, then that's going to likely cause the vessel to rupture, and then the fetus can quickly exsanguinate and die from that particular situation. A true knot in the cord, and you see in that picture there how the cord kind of gets wrapped around itself, that could cause a decrease in blood flow from the placenta, because it's kind of just like any knot. If the baby's moving around and tightens that knot, then it's going to increase the pressure on those umbilical vessels, and it's not going to allow blood flow to occur normally. And that concludes this module.